learning point which we can carry to back home. First of all, I like to thank all my co-instructors. They are actually not my co-instructors, they are actually my mentors. Whatever I am today is all because of them. So coming to the first case, this was a 32-year-old gentleman who presented to us with sudden decrease of vision in the right eye for 1 week. He consulted locally. He was diagnosed to have an optic neuritis in that eye with macular hemorrhages and was sent to us for further investigation and management. On ocular examination, his best corrected visual acuity was 6/24 and less than N36 for near, and in the left eye it was normal 6, 6 and 6. Color vision was noted to be reduced in the right eye with normal in the left eye, and the pupils was sluggishly reacting to light with no obvious RAPD. When we did the confrontation test, the patient was very characteristically saying that I'm not seeing any scotoma. No, there is no dark spot, but absolutely everything in the right eye is blurred. What I just want to highlight over here is the test. We always have a habit of writing the right eye first and the left eye first, but that is because we are all doing an objective test. When we are doing a subjective examination, always try to remember that left eye, the left hand side should be the left eye. So this happens, this you need to keep remembering yourself when you are putting up the confrontation, visual fields and Amula charts. All this, the left side will be the left eye and the right side will be the right eye. Okay. So ocular movements were full, free and painless. Other cranial nerve examinations were normal. Anterior segment examination was unremarkable. The pressures were good. And this was the posterior segment photographs of that patient. So how many of you over here will agree that what the patient was sent to us was about an optic neuritis with macular hemorrhages? Or you have some other diagnosis too? But the visual field is less and the color vision is also reduced, and the confrontation is also showing that the patient is saying that he is seeing blurred. Maybe the RAPD was not picked up well. So any other comments? So should we go ahead, or someone wants to describe the slide, especially the right eye photograph? Well, if you look very closely into the right eye disc, what you will see is something which is known as the disc collateral. This is nothing but it is actually the shunting of vessel from one region to the other region. If like the blood is not able to drain, the vessel is not able to drain the blood from that particular region, it shunts it to the other region so that the blood is carried forward. So this is actually the disc collateral. So when we went back and asked the patient about the history, what we then realize is the very serious mistake that we have done. We have not gone into the details of it. So this patient was a known patient of obsessive compulsive disorder and was been given antipsychotic medication, which was fluoxetine, and which is it is very well known that it causes CRVO. Okay, so this was a patient which having an impending central retinal venous occlusion with disc edema. Okay, so this is the reason why I will say that whenever you take an history, you have to go back and take a detailed history. Ask them about their systemic illness, their drug history, their past history, anything of this similar episodes happened in the past. So this is coming now to the second case. This was a 43-year-old gentleman. He was an office goer came with complaints of gradual decrease in vision in the right eye for 2 months. The history of some surgery which was done in the same eye. The best corrected visual acuity was 6/12 N6 and in the left eye was normal. The color vision was mild reduced. Pupils were reacting to light. There was a right eye RAPD grade 1. I hope we all over here knows the clinical grading of RAPD. I will not elaborate further. Coming to the slit lamp examination, the anterior segment showed a superior bleb in the phakic eye with the pressures which are 6 mm mercury, and the other eye has been normal. This was the right eye fundus picture, and the left eye, I don't have the photo, but the disc and macula was normal. So when you see over here, what you see is the disc edema, but what else do you find along with it? Yeah, they are macular folds, and the same slide has been shown earlier also. What you also see is an RNFL defect. Okay, it's a wedge defect, what you can see over here. So this was actually a case of hypotonic maculopathy with disc edema in the right eye with status post filtering surgery. So do you have any comments to add? So coming to the what we have to learn is a systemic examination. This case was solved because of a very systematic examination which was done. So whenever you evaluate a neurological case, what I'll request is go methodically. Like whenever first you test for the afferent function, in which you check for the visual acuity. Don't only mention the visual acuity, you need to mention which chart you have used, what was the illumination of the room, what was the distance that you have maintained. In the color vision needs to be checked immediately after the vision, because it's a sensory test in which you can use Ishihara or a Farnsworth hue test. Pupillary examination, in which you need to see what was the pupil size, whether it was equal, round, reacting to light and accommodation, whether the direct and consensual light reflex were present and they were equal in both the eyes, or whether there was in presence of any RAPD. Visual fields, confrontation and Amula test is to analyze what is the visual field like that of the patient. Confrontation test doesn't take much of time, and in the office it hardly takes a minute if you really go towards it. Brightness comparison test, if you still feel that the patient has an optic nerve problem, in that case what you can do is just take a red bottle and ask the patient to compare in both the eyes. If he feels that one eye is feeling that it's little faded, that's when you can say that's the early sign of an optic nerve problem. And the other test is the edge light pupil cycle time. Okay. Now coming to the Efferent system examination, you will see for the anisocoria, which is said to be like anything more than 1.5 millimeter, and you need to see whether it is more in the dark or in the light. More in the dark means it is it is the failure of that particular pupil to dilate, that is, it's a sympathetic problem. If it is more in the light, it means it's the fail to constrict, that is, it's a parasympathetic problem. So you need to check for the ocular motility. You need to check the patient's eye in the 6 cardinal position, which we have already seen before. Do cover tests. Saccades is fast eye movement and pursuits. And eyelid functions, like you need to see for the ptosis. You need to see whether there is aberrant regeneration of nerves or any Cogan's lid twitch to rule out any ocular myasthenia. You definitely need to examine the other cranial nerves, which was already emphasized before. So this is how a normal neuro-ophthalmological examination should be done. Now coming to the third case. Sir, do you have anything to add? So coming to the third case, this was a 32-year-old female, a housewife, who came with complaints of sudden decrease in vision in both eyes for 7 days. She was referred to us with a diagnosis of bilateral papilledema. Always remember that whenever you look in a patient for further management, but this is on the history paper, but always remember that until unless you look for a raised ICT, you cannot label a bilateral disc edema as a papilledema. So on examination, both eyes visual acuity was 6/60. Color vision was not possible because the patient has very poor near vision. Pupils slightly reacting to light, there was no obvious RAPD, and the confrontation, she was barely able to recognize the face. Ocular motility was full free and painless. Other cranial nerve examination was normal, and the anterior segment examination was normal. But when we looked at the posterior segment, what she had was all the vessels were prominent, but there was marked disc margins which were blurred. And when I show you the montage photograph, in which you can very clearly see there are pockets of fluids. So this was a clinical impression of a VKH syndrome, and the patient was advised an ultrasound and FFA. The FFA revealed pockets of fluid in both the eyes, and a B scan showed an exudative retinal detachment. She was advised a course of IV methylprednisolone. After 3 doses, the fundus pictures were taken. I'm sorry, I don't have them, but it shows a resolving phase, and the patient was later continued on oral immunosuppressive therapy. This is the last follow-up which I have of that patient, in which you can see the whole pockets of the edema has resolved. So always try to remember that whenever you see a disc edema, it's not only the neuro-ophthalmological examination that you need to see. You need to also see the other parts which can be associated. Like in this case, the posterior, there was a posterior association. If we could have missed this patient two of the pockets of fluid, we could have easily gone ahead and do as what Dr. Satyakarna has already emphasized before, that we could have gone ahead with MRV, LP and so on and so forth. So coming to the last case, this was a 42-year-old male who came with complaints of decrease in vision in the right eye since 3 months, with a known history of hypertension on treatment, which was under control. The best corrected visual acuity was 612 and 66 in the right and left eye respectively. Color vision in the right eye was mildly reduced and the left eye was normal. The pupil shows right eye grade 1 RAPD and the ocular movements were full and free. Anterior segment examination was normal. Both eyes pressures were good. The posterior segment evaluation shows a mild disc edema. You can very clearly see that the disc margins are obliterated. We did a fields, and this was a field. It was a centrocecal scotoma, and in the right eye it was absolutely normal. So what should we do next of this case? So always remember that if it was a disc edema, if you consider like he is a 43-year-old, considering that he fits in the vascular etiology, and you think of it's a non-arthritic ischemic optic neuropathy, but remember that the disc edema should show some times of resolution by 10 weeks. Since it was not resolving and it was disc edema which was seeing beyond 10 weeks, we ordered an MRI. And what we found, if you can see, this is the optic nerve, and you can see an enhancement around it. This was nothing but a right eye compressive optic neuropathy due to optic nerve meningioma. So the take home point of this case is, like, if you see a disc edema which is beyond normal routine of 8 to 10 weeks, you need to scan the patient. Okay, thank you.